Good morning, everyone, and thank you for being here so early on a holiday weekend. So my name is Michael Allison. We'll be speaking about some cardiovascular emergencies. And I subtitled this, Too Much Fluid in All of the Wrong Places. By means of introduction, I would like to thank the Ministry of Health, the conference organizers, all of the physicians here in Kuwait for the hospitality, the welcoming that you've bestowed upon me here. It is my absolute pleasure to be here with you all, and thank you. I come from Baltimore, Maryland. I've been living there for some years after I completed medical school training in New York City. I moved to Baltimore for my residency. My residency was a combined residency in emergency medicine and internal medicine both. It's very rare in the US, only 10 programs do that. It's also integrated after the first 4 years of residency with a critical care fellowship, which I completed at the University of Maryland and Shock Trauma Center in Baltimore, Maryland. And this is downtown Baltimore. Baltimore has a national reputation and possibly even an international reputation for being a particularly violent city, which is good for violent trauma training. But it's quite a nice city, and if you happen to make a trip to the East Coast anywhere between DC and Boston, Baltimore is very close. Please come visit. So I thought I'd give you a relaxing morning for a little while, since it's a holiday weekend, but then I thought, no, let's all go to the emergency department. Come with me. We're going to the emergency department, and we're going to go save 2 lives in 20 minutes, but with the introduction, and we started a little late, we gotta really go. So let's go see these patients, maybe 15 minutes. We've got 2 patients to see already, first thing this morning. We have a 36-year-old woman with dyspnea. We have a 49-year-old woman presenting with abdominal pain. So who are we gonna see first? Dyspnea or abdominal pain? We're gonna see the abdominal pain first. So we have a 49-year-old woman, she's older. Abdominal pain. 10% of abdominal emergencies end up dying in the hospital. Presentation with an abdominal emergency, 10%. So let's see abdominal pain. Here's a 49-year-old woman, abdominal pain radiating to the back. It's epigastric. It's going to her scapula. She describes it as tight. It's mostly tight. It's not radiating anywhere else. It's been going on for a few days. She has a history of coronary artery disease. She's had a cabbage in the past. This was all after she had breast cancer and had chemoradiation, which probably induced some early coronary artery disease in this woman. She presents with vital signs. Her temperature is 37.5, a blood pressure of 130/70, pulse rate of 105, respirations of 28, and saturations of 99% on room air. Not so bad. Her EKG is sinus tachycardia, no ST or T wave changes. She has a point of care troponin, which is negative. Knowing that women present differently with cardiovascular disease, we were very early to check an EKG. We already checked a troponin. But she has this abdominal pain. She has a significant history. We're going to order labs. We're going to order studies. But we have only 2 patients to see. We have only 15 minutes. She's going to CAT scan. We'll see the next patient. 36-year-old woman with dyspnea is waiting for us. She is in respiratory distress. You were right. We should have seen her first. She has a history of pulmonary hypertension. She has variable adherence to medication regimen. She has a temperature of 37.1. She's in shock with a blood pressure of 80/45, a pulse of 119, respirations of 26, and saturations of 85%. We get a quick EKG for her dyspnea, and it shows some right ventricular strain pattern. You see a tall R wave in V1. She gets a chest X-ray. There's no pulmonary consolidations. There's no interstitial pattern. There's no pleural fluid or pleural effusions. It's a little bit hyperinflated. But she's got that history of pulmonary hypertension, which is making us nervous. So by way of introduction, let's just talk a moment on pulmonary hypertension and how we're making that diagnosis. Screening's often done with echo now, but the official diagnosis is going to be made with a pulmonary artery catheter when you're getting mean PA pressures of greater than 25, a wedge pressure that's less than 15, and greater than 3 Woods units of PVR. So that's how we're diagnosing our pulmonary arterial hypertension. And back to our WHO classification, we know there are 5 subtypes. There's the idiopathic primary pulmonary hypertension, which is group 1. We have left heart failure creating right heart failure, group 2. We have pulmonary disease creating heart failure, pulmonary hypertension, that's group 3. Chronic thromboembolic disease, group 4. And then everything else that doesn't fit neatly into the first 4 categories is going into group 5, something like sarcoidosis, the great imitator. But she's in shock. This is not pulmonary hypertension. We're not dealing with WHO classifications. We are at 8:15 in the morning seeing a woman in shock in the emergency department, and she needs care now. And I just want to emphasize how sick this woman is. And I think you all probably know this, but she's in pulmonary hypertension, she's in shock, she is sick. If we look at the Journal of Critical Care article from 2012 about some prognostic factors and outcomes, we know that if she ends up on vasopressors, she has a 50% chance of mortality. If she ends up on hemodialysis during this admission, 70% chance of mortality. If she ends up on the mechanical ventilator, she has a 71% chance of mortality. If she progresses to cardiac arrest, it's almost certain mortality for her. And this is a study with a limited sample size. It's 100 patients. It's a medical ICU, not a cardiac ICU. So these numbers aren't going to be perfect, but this just tells the story of how sick this woman really is. And when our patients are really sick, it's fundamental and it's essential to go back to the basics and our ABCs. So let me take you through the ABCs of the woman with pulmonary hypertension in shock. Airway. Let's talk about airway. I'm speaking to airway experts in the crowd, and you all know that positive pressure ventilation in these patients is going to kill them. We're going to increase their pulmonary vascular resistance, and that already dilated, poorly contractile right ventricle is going to have to strain to press against that increased positive pressure. Intubation can kill these people. Putting the airway in early can kill these people. So what are we going to do? We're going to try and optimize her oxygenation, but we're going to do it the most non-invasively we can. A non-rebreather, a Venturi mask with a high flow rate of oxygen, or the nasal high flow that's now coming out. And I'm not sure if you're seeing this in your hospitals now, but these high flow catheters that can deliver 40 to 60 liters per minute of nasal oxygen through a nasal cannula, humidified and heated, that provides very little positive pressure. So you're not getting a lot of positive pressure, but it's reducing the air entrainment and giving these patients some great FiO2. So I use that a lot. Moving on from A to B, we're breathing. We want our saturations to be greater than 90%. Pulmonary arterial vessels vasoconstrict when they're hypoxic. So we want to make sure they're not hypoxic, and we want to make sure that we're getting the best compliance of our pulmonary system to make that right ventricle work easier. Inhaled nitric oxide. Inhaled nitric oxide is a potential therapy for this patient, and it's much maligned inhaled nitric oxide, fairly expensive inhaled nitric oxide, but it might help us in the acute patient. And I'll point you to a study, and this is really the only study that we have from the Blue Journal many years ago as the response to inhaled nitric oxide in patients with acute right heart syndrome. They're looking at only 29 patients. But they found that they improved cardiac output and improved stroke volume in the acute setting when they had inhaled nitric oxide, that it improved their mixed venous oxygen saturations, and that when you stopped the inhaled nitric oxide, the patient worsened again. So it was reversible, and it looked like it was due to that INO. Again, we don't have mortality data on INO, but it might buy you that extra time for these patients. So we went through A, we went through B. Now let's go to C. Let's talk about circulation in these patients. And really we want to get their mean arterial pressures back up to 65. If our left-sided pressures, if our systemic pressures are lower than our right-sided pressures, that right ventricle is going to be hypoxic. You're not filling that right ventricle with coronary blood flow. It's going to suffer. So we need to get our systemic pressures higher than our right-sided pressures. How are we going to do that? You can consider bolusing patients, right? It's usually their first reflex in the hypotensive patient is to reach for a fluid bolus, hang it, and give it. But I want to caution you in these patients, their right ventricle is overloaded. We don't know where they are on that Starling curve. It's possible that little bits of fluid can help that right ventricle on the Starling curve, but it's possible we can put them into pulmonary edema, pulmonary overload. So Small aliquots of fluid, 250 mLs at a time would be my recommendation. Not a liter hanging wide open, not even 500 cc's. Give that 250 ml bolus and then reassess your patient. But really what we're going to be going to is vasopressors very early. And with many options, there's no perfect vasopressor, but norepinephrine seems to rise to the top in many of our patients who are critically ill. And I think you don't need to deviate from your normal standard. Your nurses are familiar with the medication, so start norepinephrine early to improve contractility, to improve their mean arterial pressure. So this is our intervention. So it was a sort of whirlwind, but we improved her saturations up to 94% by placing her on 100% non-rebreather. We initiated that INO at 10 parts per million, and we're titrating that every 30 minutes. Titration is going to be hard if we don't have invasive monitoring, but you can start it without and then get that patient to the critical care unit where that titration can happen. We did a 250 milliliter bolus and had no response, and that's often the case, so we started some early vasopressors. So I think we did a good job resuscitating her. Let's go back. Let's see about our other patient. We only have a few more minutes. The 49-year-old woman with abdominal pain. Her CT comes back. The abdomen was fine, but there are some incidental chest findings. That's going to loop through again, and you're going to pay attention to the heart this time, because this woman who had radiation therapy, who also has had a history of a cabbage, has some posterior and now inferior pericardial fluid, incidentally noted. You're all going to be experts within a few years in point-of-care ultrasound when you continue to come to workshops and conferences like this. So you take that ultrasound probe you have, you put it on the patient, and you see this. You see a left ventricle in your top right portion of the screen. You see a right ventricle that's having some collapse in diastole. It should be filling in diastole. It's being collapsed. You're not giving the right side of the heart the pressure it needs. The left side is suffering. There could be low cardiac output. This is a patient that might progress to tamponade. You have to pick up the phone, you call that cardiothoracic surgeon who operated on her chest and gave her that tube bypass cabbage. And he said, remarkably, I'd be happy to see that patient. I don't want you sticking any needles in her and potentially disrupting her coronary vessels. Why don't you send her over to me and we'll see if we can get her a pericardial window. And we're feeling pretty good. Until 90 minutes later, the transport comes, the patient's reassessed. And you know what the next slide's going to show, right? She's now hypotensive. So what do we do now? We go to the bedside, we reassess, and the first thing on our mind is, we might have to drain this. Are we going to have to drain this pericardial effusion here in an emergency setting? So our drainage, we have three potential options for where we're going to drain. The subxiphoid view, we've learned that through our training. It's the landmark-based technique going up towards the shoulder. An apical drainage procedure sounds pretty scary with all that lung out apically. A parasternal, it sounds scary with that internal mammary artery right there. I don't want to stick straight down, especially if there's no anterior fluid. Here's a pictorial description of a depiction of a subxiphoid approach and of the apical approach. Another one showing you the subxiphoid approach and a parasternal approach. So what are you going to do for this patient? Traditionally, you would have gone subxiphoid, but now you have point-of-care ultrasound. And we can
5 minutes.
Take some information from the Mayo Clinic. The Mayo Clinic pioneered pericardial drainage with needles. They found that in consecutive patients, over 1,000 consecutive patients that they did, that they had the best window, not in subxiphoid, but in the apical position. And that's where they drained the fluid 68% of the time. A smaller percentage in the parasternal. What's that math? 17%, right? They reported major complications for these patients. Only 1.2%, pretty good. Major complications were anything that needed another intervention, any sort of surgery. and half were pneumothorax. Half were pneumothorax. Because they're going apically, the lung is really close nearby. So if we're doing this, we're going to do this for this woman. We're going to
5 minutes.
An apical pericardial drainage procedure. We're going to check the x-ray afterwards to make sure she's okay. So with ultrasound, you have a lot of probes. There are many different probes on that machine. And you know that cardiac probe, that phased array probe, you can see it. You've seen the cardiologist use it, and you know you want to pick that one up. But it might be better in these patients to do the abdominal probe. That curvilinear probe gives you a better image resolution of that needle. So you can do your ultrasound while you're putting in the needle and see that needle slide right into the pericardium space. Agitate some saline. Inject the saline and you'll see some bubbling around the apex. You know you're in the pericardium then. You drain the fluid. You save the woman's life. So in just a few minutes, we saved 2 lives. And let's review the key points that we want to take to our patients. First, the patient with pulmonary arterial hypertension. Inhaled nitric oxide may just buy you the time you need to do your other interventions. I don't have great mortality data for you, but if you're seeing that sick patient, I would think about initiating that early for these patients. We're going to start our vasopressors early. We can try fluid boluses, but I really want to emphasize that vasopressors early. Do not wait. Start them early as soon as you can in these patients. And our patients with pericardial tamponade, the time is now to start doing echo-guided drainage. And when you have that crashing patient in front of you and you don't have time for your cardiology consultant, your interventionalist, your cardiac surgeon to come and see that patient, you may have to provide this therapy to these patients. And I can tell you that echocardiography can make it more comfortable, can ease your mind, and make you more successful in the procedure. So I want to thank you for your attention. I think we saw these patients very efficiently, very quickly, and I'll take time for any of your questions.